lead consultant of Exeter's Gender Identity Clinic, also known as the Laurels, and chair of the UK's National Reference Group for Gender Identity Services. And John will be able to give us a local, as in UK, perspective on these issues. After that, we will have David Doyle, also present in the room, a lecturer in social psychology, and an expert on the impact of social stigma on social relationships, who will report on some of the work that we have been doing lately with trans individuals, their social networks, and service providers. And last but definitely not least, we will hear from Stewart, MB, over there, who is the CEO and co-founder of Gendered Intelligence, who is focused on improving the lives of trans and gender questioning people. Jay will be able to draw on lived experience as well as professional involvement with multiple projects where these issues have been explored. So I will start by not taking any further time from the brilliant speakers and to give the floor to Doris Chou, who is online waiting to come in.
Hello. Can you see me and hear me okay?
Yes, we can. Thank you, Doris.
Wonderful. And thank you, Manuela, and thank you all for this opportunity. And greetings from New York, where I am currently attending some meetings. So apologies that I cannot be there with you in person. It's really a great honor to be able to open this session. And I just wanted to share with you a little bit of a brief timeline for some of the things that we've been doing within the WHO to help really contribute to tackling the challenges and experiences with regard to health and well-being of transgender people and other gender minorities. And some of the shifts that have been happening within WHO, one of them that I'm going to speak to you very directly today is how the 11th edition of the International Statistical Classification of Diseases and Related Health Problems, known as the ICD, how that has really helped to frame some of the things that I think we're going to be able to speak to during the rest of the hour. I will say that unfortunately I can't stay with you the full hour, but I think Anne and Manuela and others will be able to set questions that you may have for me and or WHO if they come up after I have to leave you. So maybe just to give you a little bit of context, in 2004, the WHO published a document known as the Reproductive Health Strategy. And this was in response to a World Health Assembly resolution, which explicitly called upon the WHO to develop a strategy for accelerating the progress towards attainment of development goals and as relates to reproductive health. And while it's not stated explicitly in that document, of course, all people includes transgender persons. So the question is, what do we know about the attainment of health of transgender people? And the answer is probably not as much as we could. We know that transgender people, those whose sex at birth differs from their gender identity or expression as a group, we know that they're affected by negative health outcomes such as HIV, STIs, mental health distress, issues like substance abuse, but clearly that's not the full scope of health. And when it comes to discussing the health of transgender individuals, I think one of the things that we need to acknowledge is that what we currently know is limited, partially because in some ways when we look at how we gather health data, in some circumstances we're using things like population-based surveys. And if you just look at how those surveys are being framed, the questions are often asked in a binary way. And so this, among other issues, actually can limit access and availability of health-related services for transgender persons. And so, when we think about this, it's still very relevant to discuss what it is we do when we think about how we measure health-related matters. And so, believe it or not, by international treaty, countries have actually committed to collect and report health statistics using the ICD, which is the health information standard for coding mortality, morbidity, signs and symptoms, etc. And so it really has a critical role when it comes to framing the interpretation of health with the medical and epidemiological literature to really assess how progress is being made towards meeting public health objectives, to facilitate the access to healthcare services, and to provide a basis for clinical guidance, research studies, as well as in some cases, in most cases, to define the obligations of a state to provide care for their populations. And so ideally, ICD-derived data also facilitates the use, the collection, and the analysis of healthcare-related data across different settings. And in that way, it promotes informed decision-making based upon quantitative data. Now, the ICD is also a very, well, not very, but it is a dynamic document, and it needs to reflect current scientific practice. And so it is routinely updated, and typically editions were updated on a 10-year cycle. But what we see is that the ICD-11, which was released for public preview in June of 2018 and will be soon presented at the World Health Assembly, is now the product of over 10 years of revision from ICD-10 to ICD-11, and the product of a lot of consultative process. And so why am I telling all this in the context of speaking about the health of transgender people? It's because in the mid-2000s, discussions began with my colleagues in the WHO Mental Health Department on the revision of the chapter related to mental health conditions. And it became early on understood that there was a need to focus on the diagnostic status of the gender diagnoses, because in the ICD-10, they were part of the mental health chapter. And these discussions in the mid-2000s with relation to the ICD were happening in parallel to reports such as the Hammerberg report, which pointed out problems of classification of the transgender identity as a mental health disorder, as well as raising concerns about access to care, and even things like resolutions, political resolutions on human rights and sexual orientation and gender identity, which condemned the fact that issues like transsexuality, as it was referred to, that were being regarded as mental illnesses. And so one of these resolutions called upon the WHO, with others, to withdraw this concept of gender identity disorders from the list of mental health disorders, and to really ensure non-pathologizing reclassification within the ICD-11. And this, of course, is happening in the context of a lot of discussion in the public fora on these issues. And so really, just to bring this together, my department, the Department of Reproductive Health and Research, where I work, with the Mental Health Department of WHO, then came together to look at the classification of several entities. One of them being the former ICD-10 concepts of transsexualism and gender identity of childhood. And, we collectively formed a working group which had representation from different regions of the world and different perspectives. And one of the things this working group had to really consider was, is it a mental condition or disease if you experience or express your gender identity differently than what was assigned to you as your sex at birth? And the working group had to consider this question in the context of concerns about barriers to healthcare services, including the potential risk of loss of healthcare funding, finding a balance between stigma versus access to care, and then also very specifically the double stigma that could be happening because of experiencing a transgender experience and then having a mental health diagnosis being given to you could create a doubly burdensome situation. And then also, because these conditions were sitting in the mental health chapter, there could be an erroneous perception that you would be seen only within the psychiatric setting, which could potentially limit a person's access and availability of the full breadth of healthcare services, including things like routine preventative health care. And so just to make a relatively long but very important consultative process which went on, the working group had to first consider, should we remove this set of conditions from the ICD? And the decision was no. And then the second question was, where should it go if we don't think that it's a mental health condition? Because although being transgender is not considered a mental health condition in and of itself, limited access to accurate information and appropriate health services certainly could contribute to negative behavioral and mental health outcomes among transgender individuals. So where would these concepts go? After a lot of consideration of different places, like the NH chapter, or even the chapter where we were working very directly on, which is the diseases of genital urinary system, the idea came to maybe put this in a completely different space, a completely different chapter. And there was precedent for having small chapters where it could be shown that you really needed to unify concepts because not doing so in a classification could lead to inaccuracies in and of itself.
Doris,
And
just
so-
to say you have a minute, okay?
Yeah, based upon all these discussions and decisions, the decision was made to remove the condition of what was called gender identity disorder, to rename it to gender incongruence, and to move it from the mental health chapter to a different chapter, which is called the sexual health chapter. And it was done so in consideration of supporting access to healthcare services, to reduce stigmatization, affirm human rights, and ensure the depatholization of the diagnosis. And so there is quite a bit, there was quite a bit of discussion on this. I will say that this was reviewed widely by organizations such as WPATH, and we do know that there has been consensus for the conditions to be moved out into a sexual health chapter. We do have some evidence now from small studies from Mexico, Brazil, India, Lebanon, and South Africa, finding that moving the conditions outside of the mental health chapter, keeping it within the ICD, was very important for care for these individuals, and that it would be really important to keep these conditions within the ICD. And so I am going to stop here and just to say that the reclassification is really intended to serve as a useful instrument in the context of discussion of public health policies aimed at increasing access to appropriate services for transgender people, and to reduce victimization, stigmatization, and to work towards depatholization of the condition itself. So I really do look forward to maybe hearing some of your reactions and questions. And of course, my colleagues there will send any questions that you have on this, and afterwards, in context of the other speakers, to make so that we can respond to you. And thank you very much for your attention.
Thank you very much. Just to say, this is the microphone, so if you tap it.
That way, don't tap it.
No, don't tap it. Yes, straight on to John.
Okay. So my name is John Dean. I am a medical practitioner. My background, my primary specialisation is in family medicine, general practice. And I've worked with people with concerns over gender and sexuality probably for around 30 years. I'm going to give a brief overview of the real world, if you like, in clinical practice in the UK, and the direction of travel that healthcare practice in this country has been headed. I'm not speaking as a representative of anyone in particular, but the views I express, I think are consistent with those held and expressed by most people working to help transgender and non-binary people achieve greater well-being and health slightly. Okay, so briefly, this first slide just shows what's happened to the number of referrals made to adult gender services in England between 2011-12 and 2017 and 18. And we have seen an enormous increase during that period, and there is at the moment no real sign of that increase in referrals flattening off. Next, please. The next slide shows... The next slide shows, back one. See, this is why I have a button myself, you said, but thank you. We're seeing a similar increase in the referrals of children and young people to the UK's only specialist service for gender incongruence in young people. this mirrors what's going on in adult services, and also I think shows that the pressure on healthcare services for people experiencing gender incongruence and dysphoria is going to continue for some time to come. Next slide, please. Some changes in the landscape. This field started like sexuality, where I started working with people with sexual problems and issues concerning sexual identity and expression, began in psychiatry and has gradually moved from psychiatry, where the help was where there is some distress experienced by people experiencing such problems, that they are being pathologized and given a mental health diagnosis label. Now, I have to say that many of the people I work with a background in psychiatry, now specializing in gender medicine, acknowledge that this is a different area of healthcare. This isn't mental health. This gender medicine, gender identity healthcare practice is quite different. And the Royal College of Psychiatrists published a position statement last year which sets out a recommendation that WHO and the American Psychiatric Association remove gender incongruence from mental health diagnosis nosologies. Next slide, please. I think in specialist practice today, and probably increasing amongst health professionals generally, is the appreciation that gender incongruence is a form of neurodiversity. It is difference. It is related to a normal expression of the human genome in an unusual way, and perhaps in a way that society does not particularly value and doesn't understand. And that results in pressures and difficulties for people who experience that. It has, we see an overrepresentation in our client population of people who have other neurodiversity conditions, such as autism spectrum conditions, ADHD. These are not pathological. These are differences. They can reach a threshold of causing such impairment to people that their lives become difficult to the point of impossible as a consequence of their experience and their experience of the reaction of society and other people to them. So essentially, we move towards this as being not mental illness, but neurodiversity. Next slide, please. The alternative model, perhaps the traditional model, has been that these conditions, including gender incongruence, are a mental health issue which can be diagnosed and potentially treated and cured. I think that the whole concept of the curing such conditions is highly controversial, and current evidence is that such approaches are unhelpful and also potentially harmful. And many authorities around the world, including the National Health Service in England, have adopted a position statement that attempts to cure gender incongruence, or to assert that one form of gender expression is in some way superior to or preferred to another is unethical and not evidence-based. Next slide, please. So, the neurodiversity approach advocates that we meet people in their lives where they are today, and not to try and shoehorn them into lives and expressions of identity which are more congenial to traditional ideas. The interventions that we offer are social, educational and vocational accommodations which improve inclusion in society, to make adaptations in communication, including things like use of pronouns, adopting approaches which help people with other neurodiversity issues which make communication more complex, and also to offer a range of assistive interventions, medical and surgical, which improve quality of life, social functioning and satisfaction. Next slide, please. This is supported not just through the position statement of the Royal College of Psychiatrists, a position statement by the Endocrine Society, published last year, also identifies that medical interventions for transgender individuals, such as hormone therapy and surgery, are relatively safe and are established as the standard of care. So a lot of change in terms of acknowledgement of the benefit, potential benefit of such interventions. Next slide, please. How can we improve health and well-being? We aim to depathologise gender diversity, to acknowledge that this is meeting people where they are, who they are. We want to eliminate unwanted and unnecessary interventions, certainly. There is a tendency for when people get caught up in the healthcare system for there to be almost a driver that you go from therapy to hormone therapy to surgery, and that is everyone's pathway, everyone's experience, everyone's needs and goals are different, and we wish to acknowledge that, and we want to form with patients a process of shared decision making so that we can have individually tailored programs of care that meet their needs and enable them to be fulfilled and live happy lives. This involves not just the health service, but also informing effective collaborations with social care providers and people in the voluntary sector. We want to improve evidence-based practice. We have a limited evidence base at the moment through clinical research. It's sometimes said there's very little or no research in this field. That's not true. There are thousands. There are certainly at least 1,600 publications, which I'm aware of, which are very relevant to current interventions, and there are probably many others, thousands within extended grey literature and other areas. So there's a lot of evidence there. It's not all tremendously good evidence, and it really, really needs improving, which means that research collaborations and investment in research is essential in terms of making sure that we can offer the best outcomes and best experiences to people who seek our help in the future. So we need comprehensive and systematic data collection, collaborations on research, support for research and education, and also for joint learning for all healthcare providers, so that whether you're working in primary care or hospital practice or specialist practice, that you have access to the evidence and training to support people to meet their needs. Final slide, please. Much to the relief of the chair. That training, we hope, will eliminate unacceptable variations in practice without stifling innovation. Recently, NHS England have supported the development of postgraduate certificate and postgraduate diploma qualifications in gender identity healthcare practice, which are the first being a mark of achievement in learning, and the second being a form of evidence of competence for independent practice for people working in this field. So that when, as a person affected by gender incongruence, you seek help, you can be confident that the person that you are consulting has been trained to a standard and assessed to that standard. It's within the NHS. We're absolutely committed to ensuring quality assurance of providers, monitoring also the experiences of service users and their outcomes. And finally, one thing that we have got to do in the light of the first two slides I showed, which showed a great increase in the number of people being referred, is work towards matching capacity of assistive services with need. This is not done overnight. There are probably in this country less than 100 clinicians working in the field. We need to move to having hundreds of people who are trained to help address the concerns in a way that is non-judgmental, that it doesn't drive people in directions that they don't want to go, doesn't pathologise, but does allow them to find ways of living happily and productively throughout their lives and contributing to society.
Perfect.
Thank you.
Thank you so much.
Manuela and group, just to say, I do need to step off now. I just want to say bye. Sorry.
Carry on, David.
Okay, so I wanted to start by thanking all of you who were able to join us in the room today. We're really excited to have you all here, and also those who are joining us on the webinar. My name is David Doyle. As Manuela said, I'm a social psychologist here at the University of Exeter, and I'm going to be talking to you today a little bit about some of our work looking at transgender individuals and their social relationships, and thinking about how we can potentially harness some of the social networks that we're looking at to improve and support gender identity transition and the outcomes that we see. So next slide, please. So as Doris mentioned, and as you all now know, part of the inspiration behind the seminar was this idea of reclassification, so removing gender incongruence from the mental health chapter of the ICD. And as a psychologist, something that I can tell you is that indeed there is evidence that for transgender individuals, there is an increased burden of mental health disorders. So we see this across the literature. I just highlighted one study here, which I find to be a well-conducted study. It's a Swedish population-based national registry study of all individuals undergoing gender identity transition between 1973 and 2003. And in this paper, what they showed is that transgender individuals compared to cisgender controls who were well matched on a number of factors had 2.8 times the increased risk for hospitalization for a psychiatric problem, as well as, quite frighteningly to me, a 4.9 times increased risk of a suicide attempt. Next slide, please. So that's what I can tell you as a psychologist, but something else I can tell you as a social psychologist is that we want to think about the importance of the social environment here. So there's a temptation to look at these disparities and these numbers and think there's something inherent in trans identities or something essential about being trans that might be linked to these outcomes. But as social psychologists, we know that that's often not the case, and in this case it's particularly not the case. So a lot of my work has been looking at the concept of social stigma, and social stigma is this idea, as Doris sort of mentioned, that certain characteristics or identities are devalued in certain social contexts. And I want you to really think about that idea of stigma is not about a trait that an individual carries that in and of itself is bad or wrong or necessarily devalued, but that in a given social situation, in a culture, in an environment, they might experience devaluation because of that identity. And we can think about the mental health disparities that I mentioned as being a product of the stigma that people experience. And this work in transgender populations is relatively new, but there's a long history of this work in sexual minorities. So Ilan Meyer's influential minority stress model really talked about the fact that the disparities between sexual minorities and heterosexuals were a product of experiences with prejudice and discrimination, internalized homophobia, expectations of rejection, and all of these other factors that society is placing upon minority populations. Next slide, please. But I want to take you a step back from that even and think about social relationships and the social environment in a more nuanced and potentially holistic way. So perhaps appropriately, with this being partially sponsored by the WHO, I'm going to talk to you a little bit about how we think of social relationships as a form of health. So the WHO definition of health, for those of you who are familiar with it, talks about a state of complete physical, mental, and social well-being. And it's really the social aspect that gets left out in a lot of the research, a lot of the discussion around what it means to be a healthy person in our society. So my colleagues and I have been looking at this concept of social health and really showing how it's intimately linked to physical and mental health, and that these links aren't unidirectional. They go in all ways. So a lot of people are comfortable thinking about the fact that healthy social relationships can lead to good physical and mental health, but in fact the reverse is true as well. Poor physical and mental health can impair people's social relationships. And really importantly, some of the work that myself, Manuela, and our colleagues have conducted has been showing that stigma can also impair social relationships, so creating this sort of extra layer of burden on minority populations. Next slide, please. So, as John Dean said just a moment ago, there is a developed literature now on transgender health, on issues surrounding gender transition, things like this. But what we in our group are really interested in is what is the literature on social relationships and social networks among transgender individuals. This is limited, it is growing, excitingly for us, but my graduate student and some of my colleagues have been conducting a literature review, and what we're finding is that this sort of work tends to focus specifically on romantic partners and very close family members, and less so on things like friends, peers, extended social networks, and other parts of the social environment that might be quite important for trans individuals' health and well-being. So some of the work that we do see does in fact suggest what you might think, which is that those who are experiencing higher levels of social support and better social relationships show improved outcomes after gender identity transition. And this is true for mental health, and we're seeing some possible suggestive evidence for physical health outcomes as well. Next slide, please. So I'm going to tell you really quickly, because I don't have that much time, about a project that my colleagues and I are conducting here, which is funded by the Wellcome Center for Cultures and Environments of Health. And this is a collaborative interdisciplinary project that's aimed at looking at what are the desired outcomes of gender identity transition. And importantly, in this work, we're looking at multiple perspectives. So we're looking at trans individuals themselves, but also what do members of their social networks think are important outcomes? And then also what are the clinicians and service providers themselves telling us? And we're doing this through a number of focus groups. We've conducted 3 so far, and then those will be complemented by one-on-one interviews to get more depth and nuance around the topics and themes that are emerging from the focus groups. Next slide, please. So I'm just going to highlight really quickly for you here 2 quotes from the first focus group that we conducted, which was with trans individuals themselves. And this is, I think, really going to bring home some of the things I've been telling you earlier. So this first quote is really talking about the fact that people's experiences of dysphoria can be a product of the person in a given social environment. So that should ring bells with what I said earlier about stigma. So this trans individual said, "I was never particularly high key in my dysphoria until it came to interacting with other people. It was more about them and how they saw me than how I saw myself," which isn't obviously true for everyone, because a lot of people really do just want to change for themselves, which is perfectly fine. So I think this really nicely highlights that for some individuals, it is about seeing in the mirror something that's different than what they see inside themselves. But for others, it could just be about the fact that their social networks, that their social environment doesn't affirm or understand who it is that they're trying to express. So next slide, please. The second quote, I think, captures something that's starting to happen more and more with transitioning, and that's a separation of a physical and a social process. So this trans individual says, although there's the physical side and there's the social sex change, and there's something that's now appearing in society where in some cases it may be possible to have a social sex change without physically changing at all. So that is now starting to separate the two. And that's the second thing, is what I've experienced, of not particularly transitioning at all, but creating environments in which everybody who I interact with can see me as my eternal gender. And I think this is really important, because a lot of work in trans health thinks about what are the medical interventions we can do to improve people's lives. But there are certainly aspects that are under-examined where we can create environments in which people are affirmed and in which their sense of who they are is acknowledged by those in their networks. Next slide, please. So that's what I want to leave you with, is this idea that there is an importance in obviously continuing all of the research and all of the funding on medical interventions, but we also need to think more holistically about transgender people's health and well-being. And supportive social environments are ones in which the chosen gender identity is affirmed, and we need to start thinking about how we can support social networks through this. So for example, from the second focus group we ran with members of the transgender individual social networks, we're hearing that there's a lot of lack of knowledge of how they can support their loved ones through this process. So for example, they may not know how to deal with gender dysphoria triggers, and this is something that has nothing to do with stigma in and of itself. The social networks may be completely willing and hopeful of support, but if they don't have appropriate skills, appropriate knowledge, they may not be able to go about providing that support in appropriate ways. So thank you for your time, and hopefully we'll be able to discuss this.
This is the microphone, so careful with.
Hello everyone, thanks for having me. I'm going to start with a quote. We find the epistemologies of white medical practice, the rage of radical feminist theories, and the chaos of lived gendered experience meeting on the battlefield of the transsexual body. That was said in 1991 by Sandy Stone. I think it still has a lot of pertinence in 2019. Just to introduce myself, to put myself into a bit of a context. In the introduction to the Transgender Studies Reader, published in 2006, Susan Stryker remarks that prior to the 1990s, trans people were the object of study, transgender phenomena, but that given the surge in attention for an emerging rise in the numbers of trans people themselves taking up the position of writer, researcher and academic, also health practitioner and clinician, This marked a new wave of transgender scholarship. And I want to position myself within this sort of post-90s era of trans scholarship. I completed my own PhD in visual cultures back in 2014, and I would say my academic interests were around what people know about trans identities. What does that knowledge do? What does it achieve? What function does trans knowledge serve? I'm also co-founder of Gendered Intelligence, a charity that aims to improve the quality of life of trans people and to increase understandings of gender diversity. So prior to the 90s, much discourse attributed to a trans epistemology centred around a taxonomy of sex and gender through the fields of psychology and medicalisation of transsexualism. But now trans studies is multidisciplinary. In addition to psychology and medical-based studies, it's also studied in the arts and humanities, in sociology, cultural studies, philosophy. Importantly, trans scholars offer their own and other trans lives, identities and culture as central to the focus of their investigations and critical thinking. So there's a shift in objects studied by objective scientific empiricism to embracing subjective experiential knowledge production. And that's also been taken on by feminists, queer theory thinkers, critical race discourse. Trans studies is specifically concerned with the body politic, biopower and the systemisation of classifying and normalising bodies, specifically in terms of sex and gender. In her book, Transgender History, Susan Stryker notes the extensive medical and psychological literature that treats transgender phenomena as a personal pathological deviation from social norms of healthy gender expressions. We cannot and must not forget the histories that contextualise our current picture of trans experiences in health services. And today, in 2019, we need to continue to expose the norms and the values that underpin the sentiments of not affirming a person's trans identity, not affirming in wider society those who, like me, go against the social expectations of being assigned a particular gender. Similarly, sort of echoing what's been said already, fundamentally, it is discrimination, prejudice and endemic gender rigid thinking that creates the biggest problem for trans and gender diverse people. So my question is, similar I think to everyone's, but what cultures and environments do we need in order to meet a criteria for good health and well-being of gender diverse people? I wonder if the acts of being medicalised through the diagnosis of gender dysphoria or gender incongruence are actually producing ill health in our communities. We need a different culture, a more healthier environment, one that recognises and celebrates gender diversity. Instead, we continue to position trans and gender diverse people as a health issue, as a category, a classification in a book about diseases. Being trans is not a disease, it's not an illness, it's not a condition. Being trans is about identity. You may have seen the hashtag, trans rights are human rights. Also, we're in an era where self-declaration, the notion that trans people can be the ones who get to say what their gender is, not the medical world or the state. It is self-declaration that is at the heart of trans equality campaigning, specifically about gaining better legal gender recognition for trans people across the globe. And health services need to be part of this change. So assessment, diagnosis, treatment is a flawed model. I think we think that. I don't have any solutions or answers, but perhaps we can get to some today. Trans people navigating health services are continue to be made passive, though, to their treatment of their condition as gender incongruent and gender dysphoria, and it puts an emphasis on the responsibility on the clinicians. I think it's a paternalistic idea that a health professional gets to say who we are and what we can do with our bodies. Another quote from Susan Stryker: it's a really powerful way of feeling that I'm in control of my own body, that it's like saying, my body belongs to me and I'm going to do with it as I choose. I have the right or the ability to exercise complete control over this flesh. I live here. I don't rent. I'm not borrowing it from someone. I didn't pay a damage deposit. It's mine to do with it as I see fit. So I think we need to really think about where agency and autonomy is of personhood at the heart of the treatment of trans people. I set up Gendered Intelligence. You can go to the next slide, actually. Because I wanted to make a material difference to the lives of trans people. We specialise in the lives of young trans people, and we're a trans-led organisation employing more than 30 professionals, most of whom are trans. Trans people need to be at the centre of solving the problems of trans people, and trans communities need to be resourced. So in answering my own question, what cultures and environments do we need in order to meet a criteria for good health and well-being? The way we do it at GI is by forming communities, by coming together, by making connections around experiences, by unlearning our shame that we are made to feel about who we are and how we want to express ourselves, by being proud of being gender diverse and trans. But also we think together about how we can develop our resilience to the prejudice and oppression that we face day in, day out, in our local communities, in the institutes that we access, be they mental health services, education, the workplace, and online. Our youth groups provide what we think is a safe and supportive space where young people can explore vital questions. We provide space where it's okay to be uncertain, and I think this is particularly important for young people who are constantly asked to prove who they are to the adults in their lives, not least of all the clinicians at the gender identity clinics. With the right support, trans people can flourish. We recognise that medical intervention is not right for all trans and gender diverse people. People's explorations and expressions of their gender identity is valid at all stages, no matter where it leads. And equally, access to hormone therapy and surgical intervention can fundamentally enhance lives. So there's no one way to be trans, but I do think it's time to think creatively and innovatively about the interface between our diverse trans experiences and gender care services. And I'm going to end there because I don't, as I say, have any firmed up solutions, but I'm really excited to talk about that a bit more. Thank you very much. Cheers.
Sorry, can the three of you just come again, because we have questions from online, and then they can see your faces and it's easier to understand, to hear, so to say. So I'll start with a couple that we already received. I will then come back to the audience, just for those who came late and didn't hear me. I will come back to the audience as soon as we finish with the online questions. So the first question, I guess is directed at the WHO, but perhaps some of you have thoughts on that, which is, why has it taken so long for the WHO to declassify gender incongruence as a mental illness? Does anyone have a thought about that?
It's a long process. I think the ICD-10 started decades before it was eventually published, and I suspect that it takes quite a while through for social change to filter into policy change. So that's a mitigating
response.
Yes, I think
It's a generous response. Okay. Second question: what can policymakers do to increase trans people's sense of agency in healthcare or well-being policy? Any thoughts?
Well, there's a lot of debate at the moment around this notion of informed consent, and I think this is where we need to really drill down into the detail of what we mean by that. I guess there is responsibility on the clinician side to make sure people know what they're entering into. When does a person have full say about who they are and what they can do with their bodies? So there's like a politic around age, for example, and also things around capacity and all of that stuff. So it's a kind of an interesting area, but I think in general terms there's an appetite to engage with this model. It's happening across the globe, and there are other countries that are a bit more further down the line. I would say in the UK. You probably would quite
I would argue that the UK is is leading in this respect, in that over the last 6 or more years, NHS England have done an unprecedented level of engagement with transgender and non-binary people, listening to what to their ideas about their bodies and their lives. Now, a bit like the change in the ICD classification, it's taken far too long, and we would be the first to acknowledge that. But they have transgender and non-binary people are involved in the planning of services, have been contributed to the work of my clinical reference group on the development of new service specifications. They are contributing to the development of the new qualifications, the training and accreditation in gender identity healthcare practice, and we hope that they will also be examining people like me, be part of the assessment process to make sure that it's not my perspective that you are fit to work in this field, but actually the people who are using the services should be involved in that.
So
I would just say one tangentially but related point, which we've been hearing in some of the focus groups we've been running, which is to do with the fact that, of course, you want trans people to have agency in their own sort of transition process, but there's also this idea being expressed that trans people themselves are having to teach service providers what they need, and each time they go in for services, they're maybe having to say stuff they've said before and sort of restart a conversation. And I think so there's this idea of agency, but it also has to be streamlined in such a way that it's not putting the responsibility for, care in the person's own hands, so that they have to be the ones to say what is necessary. Does that make sense?
yeah,
I
so
think for me though, there's in terms of the assessment, diagnose, treat model, what trans people probably want to get to is what treatment might look like for them. So they don't really care about diagnosis and they don't really care about assessment. So if you start with sort of what do you want to happen, where are you up to, where are you thinking, what does sort of going forward look like in a kind of clinical terms, but also in other terms. I think the social, mental health and being in an environment that, people just don't understand you, they are the biggest factors of your poor experiences. And I think your kind of surgical intervention hormone therapy is really quite minor in a trans person's life, but in the discourse it's the major player, and you think, let's flip that, let's really think about what does a trans person want to happen. A lot of those things will be socially kind of driven.
And that's something which I think that we in the NHS we need to pay far more attention to, which is social well-being and helping people make psychological adjustments which allow them to be happy members of society. That's, I think, at the moment the focus is too much perhaps on the biomedical. We need to be comprehensive in our approach.
So another question that touches a little bit on what you're saying, especially if you take it at a slightly broader level, was will reclassification actually reduce stigma? And I guess there's two issues in there. One is what will it take to reduce stigma, and will the reclassification be a part of that? And the other one is what are the consequences of the reclassification actually? So I don't know who wants to start with that.
Yeah. I mean, I would just say one thing, which I think perhaps it was Doris who brought up, which is this idea of like double stigma. So reclassification, first of all, reclassification in the ICD, we also have to think about the fact that the DSM and other manuals and guidances say different things currently, and there's more work to be done on this. But reclassification and that step might take it so that the services and professionals see trans identities in a different way, but there's still much work to be done to change sort of societal views. But even if we accept that being trans is not a mental illness, there's still a stigma attached to gender diversity, to not expressing what is a sort of normative gender identity. And that isn't just about classification, that's about a larger societal shift, I think.
Yeah, it's very, I get it, but it's also, for people who have mental health problems, why are we stigmatising them too? But I completely understand why people do not wish to be inappropriately labelled as having a health issue, which isn't actually what their issue is. They got an issue. But it ain't mental
So
health.
how do you think this reclassification will affect practice? And so the other question focused specifically on how will it affect providers' practice and trans-specific healthcare models?
Say again.
How will the reclassification affect practice, really, of healthcare models, really?
I think for me, one of the things that I think could happen is when a trans person needs help around their mental health, when they're struggling with depression, anxiety, because they experience discrimination in society, then help may look like that. To unpack that from an assessment process for going forward for sort of physical intervention would be useful, because you don't really go to your clinician to ask for your psychological support, even though it's kind of packaged up as if you get that. So I think, a rebranding and pulling those apart would be really good. Mental health providers need to know how to work with trans people, and that's for me a diversity and inclusion issue alongside people of colour, people who discriminate around sexual, all of that stuff. That's a separate project, I think.
John, you were...
Yeah,
not
I mean, it's a very interesting point that you make. I mean, we do not consider ourselves a mental health service. We are a health service, and my first slide was about well-being and health. So our assessment, if anything, is to assess: have you got a complete picture of how your gender diversity and your experience in society is impacting on your life? And then these are the areas that you might wish to consider and think about. I certainly don't look on myself as providing a service where I'm assessing someone whether you can have hormones or surgery. That's a part of it. It's not even the main part of it. It is that generally helping people to identify those things that might be beneficial to them. And then there are things that we can signpost them to, which we may not provide. And I have to say that treatment for depression and anxiety, common bothersome mental health problems, we can hopefully signpost them to people who can help them manage those and address those conditions, not necessarily medically, in their own community, and we can offer liaison consultation to those providers who may be completely unfamiliar with working with young or old transgender and non-binary people. So until everybody in the healthcare system and social care system is fully aware and up to speed, part of our role is to help them too. We will play an important role for a while to come yet, I think, in terms of accessing hormonal and surgical interventions. But even there, we're trying to build up a much wider national network of provision of expertise that people can consult, so they don't have to travel halfway across the country for an appointment with a specialist in one setting. We want to make this much more widely available, but at the same time maintaining the standards, making sure that people who offer this advice in your local community have the same level of knowledge and access to expert advice as you would wherever you are in the country, London or elsewhere.
A very quick last question before we close the online part of this seminar, which is, does anyone know of any data on LGBTQ+ experiences in prisons? Does anyone know of that? That was one of the questions.
Yes.
Yes.
It's to answer that question in a very short period of time would be difficult. But part of my work with NHS England is chairing a working group looking at how services for people who are in prison and other secure settings who are gender diverse can their well-being can be promoted. That if you are a trans or non-binary person in prison, how can you get access to relevant healthcare? Some of it is specific to trans health, some of it's general healthcare. How you might be able to progress a social role change, explore your expression options whilst in prison. So that it's something which is being looked at. There is some literature, but a lot of literature is from the United States, and there's some pretty desperate experiences that people have had. But there's also some examples of good practice arising out of the United States. And we know, sadly, from the media that people's experiences in prison are can be pretty awful, and there've been reports of suicides
Maybe we
as
can
well
provide
as a
some
consequence of
pointers.
that.
I don't know if we can
Yeah.
respond to the questions online, but maybe we can provide some pointers you can leave. Okay, so I will close the online part of this discussion so you can get to your seats and we can continue in the room. But before we